always such a thing on. Where is it? Oh, well, maybe it will never go on. Give me 1 second. Oh, I'm really trying to do that. Just give me 1 second. There you go. Okay. Took a little bit longer than usual. Everyone, hi, this is Dr. Isabelle doing inflammation. And the goal is to achieve remission, stay on remission. Somehow there's still an ongoing process that may not be active, but it's still ongoing. So you're in remission because you don't have any more symptoms. The difference between remission and cured is that cured, you don't even have any disease that are still ongoing. What does that mean? So when you have an autoimmune disorder, if it's the DNA that has been damaged, whatever is the reason, if you have some genetic predisposition, we can't really say that you're cured. And we can very rarely say that an autoimmune or rheumatologic condition is cured, because the way we would know that is that if we back off completely off treatment and stay off treatment, and that after 10 years you haven't had any flare. Versus an infection, when you get infected by a bacteria, you get an antibiotics, you're cured once that bacteria has been gotten out of your system. You have to remember that remission is much more common than cured. Cure means that you don't need medication, you don't need anything, you don't need even your immune system to be there, because you don't have any evidence of that. There's a lot of infection. So EBV, CMV, herpes, VZV, shingles, right? That you basically are in remission. You're not cured from them. Your body knows how to handle them all of the time, and they live happily ever after. It's not an issue necessarily to have had CMV or EBV or all of those, because you're still in remission, right? You're in remission. You're not necessarily cured, but that's okay. We don't care, right? Because if you were cured, you could have it again. And do you really want to have it again? No, we don't. And so, in the sense, you don't want to have the primo infection again. That's what I mean. Sorry. So the difference between cured and in remission is that in one case, we don't know what that disease, that condition is going to do. In the other case, we assume that it's not ever going to come back, right? And that it's gone forever. So you can achieve remission. So the goal in rheumatology is to achieve full remission, so that we know that there's no inflammation ongoing, that there's no more erosion ongoing, so that your joints are not going to be eroded and are broken. And so that's what we're aiming for, is that we're aiming for no symptom whatsoever. And so often what I say to my patient is that the only time you'll remember that you have a condition is that you're taking your medicine, okay? You can still be in remission and not be on medicine. So in general, the way I approach, for example, this case, rheumatoid arthritis, we'll start a medication. So, the truth is that ideally, in the world without insurance, someone that has positive CCP, high CCP antibodies, you would actually you would like to put them on biologic. Again, what's the goal? Put patients in remission as soon as possible. So see it as a fire. To have a fire, you need a spark and you need a ground that's needed, that's propitious for fire. So if you go underwater, the fire is unlikely to happen. But so you have a spark and you have this fire, and the fire spreads. Okay. And what you're trying to do, what you're aiming for when you're starting to treat a patient with, for example, rheumatoid arthritis, is that you want to put off the fire. And to put off the fire, you don't go with a pipette, just, pipette with water. You literally take a big bucket of water and you just put up the fire, right? Or you take a big blanket and you put up the fire. And then, so that's the first time. So you put the patient in remission with, treatment and you put off the fire, then you make sure that the fire doesn't come back, right? That's important. And then slowly you back off, right? So it's kind of like this idea of put a big bucket of water, make sure that it's completely out. If you need more bucket, put more bucket. Make sure it's completely out. And then slowly you see if, how much water do you need to put? Do you need to put just a little bit of pipette of water, in this case? Or do you need anything at all? That's totally possible. That said, I would consider that still being in remission. I wouldn't say cured. Okay. So in rheumatology, we don't say cure. Now, that's me as a patient. I would say that talk to yourself as if you're cured, because why not, right? You can tell yourself, I'm cured, I'm cured, I'm cured, or remission. Whatever word you prefer, that's okay. But that's for you. As a physician, I have to say in remission. Okay. Now, once you're backing off, then you back off. Why is it so important? What does that mean? How do we achieve remission? We are always going to adjust. So based on the information we have, we are going to give medications depending on how you're presenting. Why it's so important is that we know that in some cases, some patients are going to have a more severe presentation. So for example, when I'm telling you this case of these patients with high CCP, high rheumatoid factor, I know from the studies in the literature that our chance of being in remission with just a little bit of plaquenil or methotrexate is actually very, very low. And so that's why I would prefer to go for a biologic. Then you put the insurance, and sometimes we have to put, we have to work with insurance. But the goal is to achieve remission as fast as possible based on the data that we're given. So a patient that has severe presentation, you may actually also give a little bit of steroids, because we know steroids is preventing erosion if you're giving it at the beginning. Then, you don't want to keep it on because that has a lot of side effects long-term. But sometimes you give a little bit of steroids at first, right? And so the goal is achieving that full remission as fast as possible. Once you're achieved the full remission, then you want to back off, okay? So the reason why you want to be acting fast, very fast, and put that big bucket of water is this concept of fire that I was explaining. There is another thing, because it's all science driven, right? Is that we know from studies that a stepwise approach is not as good as act fast approach. So there's a study, I think it's called the SMART study from a while ago, that showed that in the past we used to do one treatment, then another treatment, then another treatment. You would just kind of pile them up. But the problem is that you would wait, and because you would wait so much, by the time that you had the full treatment, the patients had a lot of swelling, a lot of inflammation, some erosive disease, and it wasn't the greatest. So there was a study to see, okay, well, if I put the biologic agent as soon as possible, and let's say we're going to consider that 3 months is okay without biologic, can I put patients in remission faster, and can I keep them in remission faster? And they found that, yes, that is the case. So in general, that's this idea of fire is that it's been proven scientifically, it's been proven with data and with very good studies and repeated studies that you have to first act very fast. And so we aim for a rotation of treatment as long as you tolerate them every 3 months. We say, okay, start with, so if the insurance is asking us, start with methotrexate, then move to a biologic like a TNF inhibitor. If that doesn't work, you move to another biologic or small molecule. If that doesn't work, after 3 months, you move. And so in general, I would say the vast majority of our patients get into full remission after 6 months. It is really important to see your rheumatologist during that time. 1, are you tolerating well the medicine? And 2, are you in remission? If you're not in remission, we should not be okay with just being okay, because we know that we can get you in remission. And that's probably the biggest message I want to share, which is don't settle for just fine. Like, you can reach perfection. So you should settle for perfection, nothing else. Okay, so that's really where it's at. And just to give you like another reason why it's so important is that we know that patients who reach remission faster have less, not only did have less joint destruction, less joint pain, less swelling, but they also have less need for switch of medicine. And the switch of medicine just tells us in studies, when you're looking at it, is that you cannot talk to the patients, right? When you're doing retrospective studies, but we can actually look at their change of medicine. And the change of medicine can basically just tell us that the patient did not respond anymore to the previous medicine. So, right, in one hand, you're like, well, I'm going to try this and then try that and then try this, but like just small and very little. And the issue is that, and then you're like, well, I'm feeling better, so I'm okay. But yeah, but better is not full remission. And we know that patients who are going to be like just okay have more chance of needing more medicine in the long term versus the patients who are like, no, like who are reaching full remission. Those patients are not going to need as much medication. So that is why it's so important. And you have to realize that in medicine, we're always adjusting the benefit and the risk. And so, yeah, I understand some patients are like, well, I don't want medicine. I completely get it. But you have to look at the side effects of the medicine and compare them with the side effect of an untreated condition or insufficiently treated. And so that's why I will, sometimes discuss with my patients as like, okay, those are the potential side effects of a medication, right? Remember, when I say those are the side effects of a medication, that doesn't necessarily mean you're going to develop those. It's just those potential side effects. Well, we also have to talk about the side effects of a condition, right? If you leave a condition ongoing, that causes inflammation. There's risk, cardiovascular risk, there's pulmonary risk, there's skin risk, there is just inflammation, cancer risk, and so on. And so that is really important that our patients understand what we're doing, okay? So hopefully this was helpful. And I'm just going to say hi a little bit, how I love doing this. Hi, Palmer. Hi, Jamie Forakis. Hi, Mike and Cheese. Oh, that's a cool name. And KLS, Mike Bride, and Govindin Rage, and Dr. Melinda. It's such a pleasure to see you. And hi, Keith. Always a pleasure to see you. Well, everyone, don't hesitate. If you have questions, you can always ask me. And then I will see you next week. And yeah, I'm doing really well. Thank you, Keith, for asking this question. It's always a pleasure to be here. Take care, everyone, and I'll see you next week. Bye-bye.